get my lesson. Yeah. So as mentioned, today I'm presenting on my thesis, which is looking at lifetime cardiovascular disease risk prediction and the social determinants of cardiovascular health among women who had a history of hypertensive disorder in pregnancy. And so today I'll just be taking us through the introduction and look at the aims, the study methodology, some of the results, discussion, as well as the conclusion. So to begin, when we're looking at the global cardiovascular disease burden in women globally, we can see that there's a variable distribution of cardiovascular disease among the different countries. But what we can notice, especially in Kenya, the burden of disease is moderate, which is also trending almost towards what we see in America as well as in Europe. And so looking at the overall burden of mortality rates due to cardiovascular diseases, we see that cardiovascular disease does not have as much mortality, but among women, cardiovascular disease is associated with 35%. 35% of all mortalities in women is attributable to cardiovascular disease, and of which majority of that takes place in low and middle income countries. So looking at Kenya in terms of the global burden of cardiovascular disease, that is comparing the year 1990 and 2019. So we assess the global burden, the burden of cardiovascular disease based on DALYs, which is disability adjusted life years, that takes into account premature mortality due to cardiovascular disease, as well as years lived with cardiovascular disease. And so we find that in 2019, we're actually seeing an upward trend of cardiovascular diseases. Even as women age out, we see that cardiovascular disease is still a prominent cause of DALYs. And this informs part of the work that we're doing today. So traditionally, we've had what we call cardiovascular risk factors that cuts across both men and women. And so you find on the left, we have what we'll consider our traditional risk factors. So these are behavioral as well as lifestyle risk factors. But towards the right, we have what we call risk enhancing or the non-traditional cardiovascular risk factors. And so the first three are what we consider adverse pregnancy outcomes, and also includes placenta abruptio and small for gestational age, which have not been included in this figure. But this is what the American Heart Association has been able to recognize as risk-enhancing factors for these women. And all of these adverse pregnancy outcomes have a similar pathophysiology. So you find that in addition to having pre-existing cardiovascular risk factors among these women, pregnancy itself is a natural cardiac stress test. And so because of these adaptations that happen during pregnancy, some of them do not resolve and carry on to, beyond the postpartum period. There are also changes that take place within the vessels and also reduced blood supply to the placenta that could predispose some of these women to have a bit of some subclinical cardiovascular changes. And of course, pregnancy is known as an inflammatory state, and this has been shown to be associated with an increased risk of cardiovascular disease. And it has also been postulated that there's a shared genetic risk between some of these adverse pregnancy outcomes as well as cardiovascular diseases because of the shared genetic link. And so what happens to these women? You have changes that take place within their heart. So the heart becomes enlarged and there's reduced compliance. And in the blood vessels, you find that there's a bit of some dysfunction, especially within the lining of the arteries. And so that predisposes them to high blood pressure and other cardiovascular changes. And so these women end up with cardiovascular events that can either be non-fatal or fatal and include ischemic heart disease, carotid artery calcifications, as well as stroke. And so when looking at hypertensive disorders of pregnancy, in Kenya, we have a prevalence of between 5 to 10%. And these hypertensive disorders are conditions that are marked by elevated blood pressures of around 140/90 milliliters of mercury, but are classified depending on the onset and some of the clinical factors. And so for gestational hypertension, usually begins after 20 weeks of gestation and should resolve before 12 weeks of pregnancy. Preeclampsia is gestational hypertension, but now you have target organ dysfunction within the liver, kidneys, within the placenta, as well as now when it has neurological complications is what you get eclampsia, and then there's the other form of HELLP syndrome, which is a constellation of the symptoms of hemolysis, elevated liver transaminases, and thrombocytopenia. And so looking at specifically gestational hypertension and preeclampsia, which have been studied mostly, we find that women have a 2 to 6-fold higher risk of cardiovascular events as compared to women who had an intensive pregnancy. And so for this thesis, what you were looking at was determining the lifetime risk of cardiovascular disease development using pooled cohort equations at 6 months postpartum for women with and without a history of gestational hypertension or preeclampsia. And we're also investigating the association between social determinants of health and cardiovascular disease risk at baseline, which was at 6 months postpartum, and at 12 months to 24 months postpartum, specifically in women who had gestational hypertension or preeclampsia. So we are going to focus on the lifetime cardiovascular disease prediction. And so this brings us to the question in trying to understand what are some of the assessment tools that we can be able to use. So the 4 here that have been listed were developed and validated in Europe as well as in the US. And majority of them calculate a 10 to 15 year lifetime or a lifetime cardiovascular risk. And they utilize patients who, the sample cohort that they used were patients who are middle-aged to elderly. And so we find that they have been, their use outside high-income countries is a bit limited. And so apart from the Q-risk score, the rest didn't have a multi-ethnic ratio, a multi-ethnic sample that could allow use in other countries outside, for example, Britain. And so the WHO, or the International Society of Hypertension, also developed their own cardiovascular risk prediction, which is region-specific to all the 21 global regions, and it just calculates a 10-year cardiovascular risk, but it's not well-developed, well-validated. And so we have the 2013 American Heart Association and American College of Cardiologists pooled cohort equations, which provide sex-specific and race-specific 10-year and lifetime cardiovascular risk for people who are aged between 20 to 79 years. So if you're above 40 years, you get both the 10-year and the lifetime risk, but if you're below 40 years, we just calculate the lifetime cardiovascular risk. And so in Kenya, what we looked at is, yes, there are a lot of published studies and a lot of evidence that has shown there's a heightened postpartum cardiovascular risk following gestational hypertension or preeclampsia, but we find that the utilization of these cardiovascular risk assessments are limited or not even in use. And so this presents us with a missed opportunity for early cardiovascular risk detection and prevention, because some of these women who had some of these adverse pregnancy outcomes sometimes tend to present later into care two or 3 years after the pregnancy, and they were not monitored. And so this presented us with a missed opportunity that we thought we could find a way to assess them. And so, as I mentioned earlier, the first aim was looking at the lifetime risk of cardiovascular disease using the pooled cohort equation. And we hypothesized that women who had a history of gestational hypertension or preeclampsia will have a higher lifetime cardiovascular risk as compared to women who had an intensive pregnancy. And so the pooled cohort equation, this is just how the calculator looks like. So the first part, we have the sex, which only gives binary options of male or female. The age is 30, so it will indicate to us that if the age is below 40, they will not be able to calculate a 10-year risk. And then race is white, African American, or other. And because our subset was within Africa and Kenya, we used the other risk category. And so below here, we have the labs, which are total cholesterol, HDL cholesterol, and systolic blood pressure. So you have values that you can input that depending on the ranges. So the only issue we had that has been there is sometimes you might have, for example, systolic blood pressure of 220, where you cannot be able to put at 20, but you can cap it down to the maximum value, but this doesn't affect the overall performance of the calculator. And then also a personal history of diabetes, smoking history, as well as whether they're on any antihypertensive. So if you look above on the top right, it gives you the lifetime ACVD risk. So the first part, which is 39, will give you the calculated risk. And if you control for all factors in terms of any intervention, the risk will drop down to 8%. So this is what these numbers mean. And if, for instance, our patient was above 40 years, it will also have given us a 10-year ACVD risk score. So in terms of our study design and setting, this was a longitudinal analysis of a 3-year prospective cohort study by Dr. Alfred Dosoti that was looking at the risk and correlates of metabolic syndrome among women who had hypertensive disorder in pregnancy, as well as gestational diabetes from 6 months to 36 months postpartum. And it was conducted in Kenyatta. And so for a study population, we had 243 women who had gestational hypertension and preeclampsia or were normotensive. And we did not include any with missing data or gestational diabetes history as a standalone diagnosis at 6 months postpartum. So we grouped women who had gestational hypertension or preeclampsia as exposed and those who had a normotensive pregnancy as unexposed. And our outcome was the lifetime cardiovascular risk, and this was further categorized as high if it was equal to or greater than 39%, and low risk if it was less than 39%. So in terms of our analysis, we used the pooled cohort equations to calculate the predicted lifetime risk. And then I'd mentioned us winsorizing out-of-range laboratory indices, but this did not affect the overall computed values. And then we also compared cardiovascular risk factors and lifetime risk scores at 6 months between normotensive women and those who had gestational hypertension or preeclampsia. And our significance level was at 0.05, and all analyses were done in R. So in terms of our baseline social-demographic characteristics, all these women had similar age at around 33 years. Most of them were married. In terms of educational attainment, most of them had a high school education or higher, and majority of them were self-employed. In terms of gestational delivery, so women who had gestational hypertension and preeclampsia had lower mean gestational age at 35.6 weeks compared to 38.5 weeks for women who had a normotensive pregnancy. And in terms of previous pregnancy complications, women who had gestational hypertension had a 94% risk of 94% proportion of a previous history of hypertensive disorder of pregnancy. And in terms of clinical measurement for the systolic blood pressure and diastolic blood pressure, they were definitely higher for the women who had gestational hypertension and preeclampsia, and even for the body mass index, as well as waist circumference and waist hip ratio, we tended to be high in this particular group. In terms of the physical and biochemical characteristics at 6 months postpartum, systolic blood pressure was significantly higher by around 16 millimeters of mercury for the women who had gestational hypertension and preeclampsia. And for the women who had diastolic blood pressure, it was also significantly higher by around 12 millimeters of mercury. Of note, at 6 months postpartum, the women who had a history of gestational hypertension or preeclampsia, only 34% of them were on medication. We didn't have the history of diabetes was only 2 in the women who had gestational hypertension or preeclampsia, and we did not have any smoking history. Total cholesterol for both groups was elevated, but slightly higher among the women who are normotensive. So in terms of lipid profiles, LDL cholesterol and HDL, they were not significantly different. Triglycerides were significantly higher for the women who had gestational hypertension or preeclampsia. And in terms of the body mass index, even at 6 months postpartum, it was still elevated for both groups at obese. And when we compared the mean difference from enrollment, we found that there was an increased risk of BMI at 1.7 for the women with gestational hypertension or preeclampsia, and 2.3 for the women who had normotensive pregnancy, but this was not significant. So the lifetime computed risk was 23.7 for those who did not have any gestational hypertension or preeclampsia. And for those who had gestational hypertension or preeclampsia had a higher risk of 34.7, and this was significantly different. And so in terms of the risk categories, we found that women who had gestational hypertension were 2 times more likely to have a high risk of a high risk that was equal to or greater than 39% compared to those who were normotensive. So this brings us to our discussion, and where we were able to compare with previous studies and found that the high postpartum lifetime cardiovascular risk was consistent with other studies. Even those that used a different computational method, it was still consistent. And for those women who had an normotensive pregnancy, around a third of them still had a high risk that was equal to or greater than 39%. And we postulated this to be due to late onset gestational hypertension or preeclampsia. So in our study, because most of these women had in the previous study had been enrolled or recruited around their delivery period, so it's possible that most of them had early onset gestational hypertension or preeclampsia, which tends to occur at least 37 weeks before 37 weeks of pregnancy. And for late onset gestational hypertension or preeclampsia, based on current studies, it can occur after delivery up to 6 months and even beyond. So we do not have a specific timeline. But also for those who might not have had any late onset gestational hypertension or preeclampsia, pregnancy itself had a role to play because of the cardiac changes that take place during pregnancy, and maybe they had not resolved, and some of these women could have had subclinical cardiovascular risk factors. So in our setting, what we found to be predictors of high lifetime cardiovascular risk were significantly elevated blood pressures as well as diabetes history. Although we had elevated total cholesterol, this was not significant. And compared to studies that have been done in high income settings, we found predictors of high lifetime cardiovascular risk to be elevated blood pressure, total cholesterol, diabetes, as well as a current smoking history. So the reason why we do this lifetime cardiovascular risk prediction is to be able to help us see a way to mitigate and reduce the risk for these women. And so depending on the risk, your risk category, there are various interventions that can actually be instituted within the postpartum period. And some of these have been documented to be very effective, including having a heart-healthy diet, adequate physical exercise, which is a minimum of 75 minutes of moderate intensity activities within a week, weight management and tobacco avoidance, which in our setting was not a factor because none of the women had a smoking history. And statin therapy may be appropriate, especially after 6 months, 6 months postpartum, because of its risk during lactation. So in terms of study strengths, to the best of our knowledge, this is the first study that has used pooled cohort equations to predict lifetime cardiovascular risk among postpartum African women in a low and middle income setting. And it has also given us a comprehensive understanding of cardiovascular risk for these women, and can also help inform postpartum care for these women, and also paves the way for more validation studies that consider female-specific and traditional cardiovascular risk factors, because the original pooled cohort equation just considers traditional risk factors. So this is one of the studies that could help us to include some of these risk factors that are risk enhancing. So in terms of our limitation, because of its limited validation in African cohorts, some of its performance may be influenced by variable cardiovascular risk factors. So you find in our cohort, we did not have any smoking prevalence. And also the focus on early onset gestational hypertension or preeclampsia may limit the generalizability to just this group and excludes late onset cases. So in terms of conclusion to our summaries, in terms of conclusion to this study, is that a history of gestational hypertension or preeclampsia correlates with high predicted lifetime cardiovascular risk. and early postpartum cardiovascular risk assessment is necessary for us to be able to give these women the necessary interventions during the postpartum period in terms of lifestyle modifications as well as targeted pharmacotherapy. And this study also advocates for the integration of a comprehensive cardiovascular screening and management within the postpartum period. So this takes me to the second part, which will be looking at the social determinants of cardiovascular health for these women. So looking at post-pregnancy hypertension after gestational hypertension or preeclampsia, there's a study that was done by Verbeek in the Netherlands that was looking at the cumulative incidence of hypertension, comparing women who had hypertensive disorder of pregnancy, as well as women who were normotensive during their pregnancy. And so what you can appreciate is the cumulative burden of hypertension as the years increase since the delivery. But of note is the women who had HDP had a higher cumulative burden, which is denoted by this top three lines, and this below denotes the women who had a normotensive pregnancy. So there's still a risk of that. And when looking at the hazard ratio of hypertension, comparing the years since delivery, we find that the highest risk is actually less than 1 year, and at around 1 year since delivery, the risk is above around 8. And even as you go to the 5th year since delivery, you find the risk is around 4, especially for is above 4 for gestational hypertension. And when you look at the 20th year mark, the risk is around 1.5 to 2 for these women. So this still shows a higher risk of hypertension given a history of gestational hypertension or preeclampsia. So looking at the social determinants of health, these have been defined by the CDC as well as WHO as the circumstances of their surroundings in which individuals are born, reside, acquire knowledge, labor, or engage in any physical activities, practice religion, or grow old that tend to impact their overall health, welfare, and lifestyle satisfaction. And so they include it's a 5 categories. So you look at your healthcare access and quality, the neighborhood and built environment, as well as economic stability, the social community context, education access and quality. So when you look at the social determinants of health, previous studies have shown that an increase in social demographic hardship would result in poor maternal health and pregnancy outcomes, and this results in a higher cardiovascular morbidity, mortality, and health disparities that have been noted, especially in high income settings. But looking at the influence of social determinants of health on cardiovascular onset and development, this has been well established, but for women who are within the postpartum period and those with gestational hypertension or preeclampsia is still undetermined. And this informs us why we were investigating the association between social determinants of health and cardiovascular disease risk at baseline. And we're looking at comparing the risk at 12 months and 24 months among women specifically who had a history of gestational hypertension or preeclampsia. And we postulated that if you had a severe social demographic burden, you'd probably have elevated cardiovascular risk factors. In terms of the study methods, this was also a longitudinal analysis that used a prospective cohort study by Dr. Osoti, conducted in Kenyatta National Hospital. And so we focused on 104 women who just had gestational hypertension or preeclampsia, who are 26 years and older and had complete medical records at 6 months and had been followed up to 24 months. So the exposure was the aggregate social determinants of health burden score, which was between 0 and 4, with 4 indicating the highest burden. And so it included educational level, self and partner's income level, and household size. And the primary outcome that we had was blood pressure, and secondary outcomes that I didn't include here were cardiometabolic risk factors. So the secondary outcomes we looked at were lipid profiles, as well as fasting blood plasma glucose and body mass index. And the covariates we had was self-reported age, and dietary intake was binary categorized as as adequate or inadequate, depending on whether they had a history of taking a dietary intake of vegetables and fruits, which was 5 or above. And cooking oil use was categorized as healthy if they were using unsaturated fats, and unhealthy if they were using saturated fats and trans fats. And for physical activity, was categorized as adequate if they had a history of at least 150 minutes of moderate intensity activity, or 75 minutes of vigorous intensity activity per week, and inadequate if it was inadequate for that duration. And so we used linear mixed models to run the model, and Satterthwaite's method to generate p-values at an alpha level of 0.05. And so this was the model equation where the outcome or the dependent variable was the cardiovascular risk factor, and the main predictor was the social demographic health burden. Time was also a secondary predictor, and then we had an interaction term between SDOH burden and time, covariates, and then we had a random slope for time, as well as a random effect for the participant ID, and E was just to allow for any errors between participants. So in terms of the results that we had in terms of the baseline social demographic characteristics, most of these women were married, and most of them had high school education. And in terms of occupation between self and partner, most of them were actually self-employed. And in terms of the household size, the median was 2, so it was generally similar for most of these women, and all of them resided in an urban area. In terms of the cardiovascular risk factors, so these women still had elevated systolic and diastolic blood pressure at 6 months postpartum, and total cholesterol was also elevated. And in terms of body mass index and waist circumference, these were also still elevated at around 32.7 for BMI, and almost at 97 for the waist circumference. And so, as I said earlier, only 34% of these women were on medication, only 2 were diabetic, and 2 were on alcohol, had a history of alcohol consumption. There's no history of smoking, and they had adequate history of lifestyle factors in terms of diet and physical activity. So just a brief orientation on the social demographic, social determinants of health burden. So this was looking at the prevalence of SDOH by domain. And so what we have in orange is the favorable risk, and what we have in blue is the unfavorable. So this was some majority of the women in terms of educational attainment had educational status that was less than high school or lower. And in terms of self, majority of them were employed or informal. So employed meant informal employment or self-employed, and it was also similar to the partner's occupational status. All of them resided in an urban area, and for the household size, most of them had a household size that was more than 2 adults. And in terms of the total SDOH burden, we find that most women were within the moderate SDOH burden as compared to the other scores that had minimal values. So in terms of the changes in blood pressure by SDOH burden, first we can see, so on the left we have SDOH variation, systolic blood pressure variation by SDOH burden. And so we have the category, the various SDOH burden. So what we have in orange is no SDOH. So these people had optimal, these women had optimal systolic blood pressures that did not change much over the 24 months. But what you can note, people who had moderate SDOH burden, so these are people in the 2 or 3 category, they actually had the most decrease in systolic blood pressure over time. But the people within the highest SDOH burden still had elevated systolic blood pressures that were still elevated even after the 24 months. And this was similarly echoed in the diastolic blood pressure. So we're seeing similar trends across the different SDOH burden. So in terms of the effect of SDOH burden on blood pressure, we saw that SDOH burden had an insignificant rise in blood pressure. And so what we saw is looking at this SDOH on its own. The mean expected change in systolic blood pressure for every 1 unit increase in SDOH burden among observations that were taken within the same time, age, lifestyle factors was around 1.79 millimeters of mercury, but this was not statistically significant. And looking at diastolic blood pressure, it was around 0.889, so this was a slight rise. Of note in terms of the covariates, age seemed to be Age seemed to be a significant factor that was associated with a positive rise in mean systolic blood pressure changes, as well as healthy diet, which shown an inverse trend. But this was only significant for systolic blood pressure. And looking at adequate physical activity, it was also significantly associated with a mean increase in systolic blood pressure at for the women for the women within for the systolic blood pressure category, but this was not significant for the diastolic blood pressure category. So overall, differences in mean systolic and diastolic blood pressure by SDOH burden did not depend on time because we didn't see any significant changes. So in terms of the other secondary outcomes, there are no significant associations that we saw between SDOH burden, time, or dietary intake, or other lifestyle factors, but what was slightly significant was the body mass index and time, where we saw a 0.06 decrease in BMI with a unit increase in post-delivery interval by a month when all factors were constant. So in terms of our discussion, what these results show us is the diverse blood pressure changes across the different social determinants of health groups. And so for those who had optimal social determinants of health, we find that the blood pressures were optimal and consistently stable over the time frame from 6 months to 24 months. But those who had modest SDOH burden, we actually saw the greatest improvement in blood pressure control over time. And this was very significant, showing that there's a potential to reverse some of these cardiovascular risk factors within this period. And so for the women who had the most severe social determinants of health burden, there's a very minimal change in blood pressure, and this could be attributed to the cumulative effects of individual social determinants of health factors. And so this shows that some of these women would actually benefit from more support even during their pregnancy to the postpartum period. And because we didn't see any significant trends between social determinants of health burden and blood pressure, but we had significant age factor and lifestyle habits, we can be able to see a role of individual factors and behaviors, as well as demographic factors that tend to play a role on blood pressure, in addition to having social determinants of health burden. So the overall strength of our study was having a longitudinal analysis that provided valuable insights into the postpartum cardiovascular health of these women. And this will help us to be able to develop appropriate targets and support them depending on their social determinants of health burden. And in terms of the limitations, we had an outcome missingness of around 25 to 28% due to loss to follow-up, especially from the 12-month to the 24th-month mark. And this was attributed to the period when the study was taken, and this was when the study was conducted, and this was during the COVID-19 pandemic, where we had a lot of lockdown measures within Nairobi. And so this could have impacted our overall follow-up and the study's power and precision. However, using the linear mixed models, they were robust enough to handle the missingness that we saw. And so we chose not to do a complete case analysis in this scenario. And also the fact that we collected social determinants of health at burden at baseline, we're not able to model or to see any changes over time because we had almost a 1.5 year follow-up period. but our findings still remain consistent with previous studies. So in conclusion, a high social determinants of health burden is associated with elevated and variable blood pressure changes over time. And it's very important to incorporate social determinants of health into cardiovascular risk assessment, especially during the postpartum period, so that we can be able to have timely and targeted interventions for these women and to reduce the risk of cardiovascular disease and events. So as I conclude, I'd just like to appreciate my thesis chair, Dr. Sarah Masyuko, as well as my committee, Dr. Logeneka and Dr. Osoti, who have been very helpful throughout this period, and also Dr. Fitzpatrick for her contribution during the start of this proposal, and the University of Nairobi meta-study team, who have been very instrumental throughout this process, and even the University of Washington Statistical Consulting Services, who are very instrumental in helping me model some of these models. So with that, this is the end, and thank you so much for your attention, and I'll open the floor for any questions.